Hello friends, this is your surgery ka dost, Dr. Rakesh Mittal. So, my first topic is hernia. Hernia is a very simple topic in the sense that one of the commonest conditions surgical residents, surgeons encounter, face in their surgical career. Very commonly done surgery, but technically it's not easy. Understanding hernia is very important, very difficult also, because it's all based on anatomy. So to understand hernia, you just know the anatomy, just remember the anatomy. Okay, without wasting time, so as I told you, we'll be discussing it in the form of MCQs, and I have picked up all the MCQs which have been very frequently asked, the 10 most commonly asked areas, whether it's theory or your clinical classes, bedside discussions, practicals, exams, MCQ exams, and even MS final exams. You will find it highly relevant, very useful. Okay, so first is, all of the following are preperitoneal inguinal hernia repairs except. This question I have made it myself. It hasn't been, I haven't seen this question being asked in exams before. Okay, so there are four surgeries mentioned here. TAPP, that is trans abdominal preperitoneal. TP is total extraperitoneal. STOPPA's repair and Lichtenstein's repair. First of all, what is common to all these and what are the differences? The first two, A and B, these are laparoscopic repairs of inguinal hernia. TAPP and TEP, there are laparoscopic repairs. STOPPA's and Lichtenstein's, they are open repairs, open surgeries. They all are mesh-based repairs. Okay, everything is relevant. Okay, a question can be asked in any way, even in your clinical classes, your practical exams, teacher can ask you about any of these procedures and ask you which one, does it use mesh or not. So TAPP, all laparoscopic repairs use mesh. STOPPA's, Lichtenstein's, they all use mesh. Okay, now preperitoneal. TAPP and TEP both are preperitoneal. In this, basically, we place mesh in the preperitoneal space. Let me show you. Right? Laparoscopic repair. See, we make an incision at the umbilicus. That's a telescope going inside. This is the rectus and this is peritoneum. And we place the mesh. That's a preperitoneal space. Okay, in front of peritoneum. So in TEP, that is total extraperitoneal repair, we enter directly into the preperitoneal space and we place a mesh here. Now TAPP, what is the difference? Transabdominal preperitoneal. Look at the terms. This is total extraperitoneal, whereas this one is transabdominal preperitoneal. The end result is same in both. Okay, now this is TEP, total extraperitoneal. See, nowhere we have entered the peritoneal cavity. Okay, we remain totally extraperitoneal and we place a mesh in the preperitoneal space after reducing the hernial sac. This is what we mean by TEP. Okay, now TAPP. The route is different. The same, we make an incision here, right? We go through the peritoneal cavity. We first enter the peritoneum and then we create this preperitoneal space and then we place a mesh. So transabdominal preperitoneal. So that's the only difference. End result is same in both. We place a mesh in the preperitoneal space, but in TEP we directly enter into the preperitoneal space. We don't enter the peritoneal cavity or the abdomen. Whereas in TAPP we first enter the abdomen and then we create a preperitoneal space and we place a mesh. I hope it is now very clear to you. This is STOPPAs. Old examiners still are very fond of asking about STOPPAs. Nowadays, after this laparoscopic repairs like Lichtenstein's, people are not doing, I haven't seen in last many years anyone doing STOPPAs. But it was old technique, 80s, 90s, early 2000s. When laparoscopic repairs were not very popular. So STOPPAs was a mesh repair. Right, this is also called GPRVS, Great Prosthesis Reinforcement of Visceral Sac. Prosthesis, so it's a mesh repair, right? A large, see, that's the abdomen. So basically in this we place a large mesh in the preperitoneal space. See, that's a mesh. This is the peritoneum. These are the recti muscles, both sides. So again, between the in front of the peritoneum, this is open surgery. Remember, this is not laparoscopic. Okay, we place a mesh, large mesh, to cover the entire myopectineal orifice. Covers entire I have a question about myopectineal orifice later, you should know. Entire myopectineal orifice. That includes defect for direct inguinal hernia, that is Hasselbeck's triangle. Defect for indirect inguinal hernia, that is the deep ring. And it takes care of also the femoral hernia. So all the three groin hernias are covered with this mesh. Okay, that's the advantage. STOPPAs. This is Lichtenstein's. In Lichtenstein's, this is again open repair. This is again a mesh repair. Okay. Now in this, as you can see, that's a spermatic cord. A mesh is placed. Mesh is placed outside the fascia transversalis. That is, it's not preperitoneal, right? It's outside on the top of the floor of the posterior wall of the inguinal canal. So this is not classical preperitoneal space. So this is the answer here. Okay. So answer here is Lichtenstein's. Lichtenstein's, we place the mesh from outside. We are not putting it in the preperitoneal space. Rest three, I have shown you the mesh is placed in the preperitoneal space. Right. So now let's move on to the second question. In a strangulated inguinal hernia, which part of the sac should be opened first? Okay, so that's a normal hernia, means the anatomy of the hernial sac. That's a wall, that's a defect, that's a hernial sac. Okay, now that's the defect is the neck. Neck is the defect through which the hernia pops out. Right, and neck is the smallest part. Okay, now this is the main body and this is the fundus of the sac, hernial sac. Now there are two places we can open. We can open, whether we should open at the neck or we should open at the fundus. Okay, now if you open the neck, neck is, because it's a narrow ring, it is holding the contents of the sac. If you cut the neck, what will happen? The contents will immediately slip back into the abdominal cavity. Suppose an example, inguinal hernia. Okay, inguinal hernia, the bowel is outside, it is strangulated. If you release the deep ring, immediately the bowel will slip back into the abdomen. You won't be able to see it then. In a strangulated hernia, what do we mean by strangulation? Strangulation means when the neck is tight, the vascularity of the contents is compromised, it's reduced. So, contents can become gangrenous. That's called strangulated hernia. Any hernia can get strangulated.